All right. How we get going?
Let's see. I don't even know what it is.
Welcome, everybody. First off, we'll start out with some acknowledgements. The leaves around the office are rather prolific. There's a lot of them, which means that there's a lot of people thanking other people for stepping up, doing things, being supportive of each other. There was a couple that were delivered, to Donna, dealing with some issues with the oscillator, and another one the other day to Jeremy from CTU for taking care of his patients and doing an excellent job up there. It happens every day. Every day you guys go out of your way to do what's best for each other and for the patients, and just want to acknowledge that. Carrie does a great job providing opportunities for you to have things to fill out to acknowledge each other. So we're going to, every month, take these wonderful leaves or whatever she's got in store for us for Christmas. We're going to put them in an envelope and we'll have a drawing. So at each meeting, and then you'll get a prize. This time it happens to be your choice of a gift card, either from Dunkin' Donuts or from Quick Trip, because who doesn't need gas, right? So we put all these in here. And we'll have John reach in, pull out a lucky winner.
That's not one for Daryl? Oh, it's too late. All right.
Hopefully they're here, whoever wins. Is that Kara?
Correct, yep.
Kara.
She's on her way with the oxygen tank for our Medinet. She's on her way, so she should be here
Oh,
shortly.
okay, well, great. And this was just an acknowledgement to Kara for helping out in the ED, and that was from Mary. So she'll get her choice of a gift card.
We'll just give her the gas. That's what she did. Yeah.
Just this great that you acknowledge each other. In that regard. She gets her choice. All right. Next, bonus program. As you all know, we've instituted a bonus program for respiratory therapy for the next 12 weeks starting November 20th, just to kind of help support us in this time of need. I initially put out an email with folks that had indicated that they wanted to be part of the bonus program. We've had a few changes in that list, so I'll send out a modified list here once it is truly final. Just because as questions come up and people come in and talk to me and we talk about the commitment, because it is a commitment of who's going to participate in the program. So far we have a pretty even balance of night shift, PM shift, and day shift, because really we have needs on all three shifts. People pick up all the time, people step up and do extra. This is just one way we can help support people that do it, and also help the department know that we have folks to be able to fill the shifts that we need to make sure we are meeting the needs of our patients. So, if you have more questions about that, please come in, stop in and talk to me. It's the best way to get those questions answered. And then I want to work on the RT homepage is moving forward. I just gonna, woo! Am I going previous?
Yep.
Okay, so how much, I have to hit control first? Where's my little mouse? Why isn't this working?
There.
What did I let that thing? It's worked totally in my office. It worked just absolutely perfect. It is control, right?
Just try clicking and see if that works.
Are you getting anything?
Oh, it's okay.
making it bigger. So this is the raw. It's pretty raw yet, so it's not completely finished. But basically, when you open up the home page, over in this corner, you have my roles, and your role will have a little link here that says respiratory therapy. And when you click on it, it's gonna pull up our home page. So right here, these things are all current events. Department meetings, education opportunities, those type of things will be added and loaded there. Here is all your frequently used documents. So if you need a fax cover sheet, or if you need forms, equipment inspection, those type of things, all the forms that we typically use are all in there, meeting templates. Also down here, one of the hardest things to navigate is on base. So if down here are your policies and procedures. So if you click on, these are hyperlinked, so it'll take you straight to it. You don't have to search for it, it'll take you right there. We will update this every 2 weeks to a month. We'll kind of see how it goes. Your frequently called phone numbers, those type of things. Just kind of a one-stop shop for you to be able to go to, so you're not having to navigate through a bunch of different areas. API will have a link on here and those type of things. So hopefully this tool will be useful, a place that you can go and access and kind of see what's going on. This should be available soon. A lot of these links we had some issues with, but everything's working out. Julie Reigel's going to help be the administrator for learning how to update this, but it's really, once you know it, it's pretty easy. So it's kind of cool. Quality measures. So, a couple of highlights: hand hygiene and PPE, RT. There was 4 observations of RTs for the month of October, and you were 4 for 4. Woo! Congratulations, doing the right thing and being visible doing it. That's very important. And our pressure ulcers were 0 for the month of October as well. I had the wound care nurse stop me in the hallway and sing the praises of respiratory therapy. Knowing the steps that we've made as far as oral care, tube movement, protective barriers for patients' noses on BiPAPs, being aware of skin integrity, she says that that is a main contributing factor to this. And she acknowledged respiratory therapy's role in that. So that was very cool to have her do that. Oh, is this working? Your hard work and the things that we do, it's just kind of normal things that you do make an impact, and this is one way that's very visible that you can see that happening. Is that not opening? What's that saying? Is it broken?
You should click on okay.
Click on okay? That's where I did that already. Okay. It's not working. Basically, those are the quality measures, our C. diff rates, our quality rates, those type of things that there's a major focus on for this organization to improve. They have been making significant improvements in many different areas. One thing that they did notice this past month is we've had quite a few catheter-related, not catheter, but invasive line-related infections. So that is another thing that we want to kind of keep an eye on, and if there's any initiatives to help us improve that, because there's a significant amount, and there hadn't been for a long time. Now all of a sudden we had a bunch. So they're going to try to figure out, okay, what caused that. So we may have some more education on that. Oop. Dang it. Oh. Here they are. We have a lot of zeros, and that's a good thing. Billing stars, there's quite a few people on this list again. This is a pretty significant improvement, Julie?
Yes, yes, thank you. Makes my job easier.
We also have a report. Everybody knows that reimbursement for medications now is tied to your documentation that you gave it. So scanning that med, making sure you sign up your MAR are important pieces of that puzzle. There is a real-time report that is going to be looked at pretty much every shift to help make sure that we are getting that done. And yesterday when Jill was helping us take a look at it, what do we have in there, Donna? We really did.
One thing we noticed is that this is something new that we need to charge, or not charge, we need to sign off the pentamidine on outpatients because they actually get a MAR generated. So the lady from the day before was showing up in a missed queue. And when I went into her chart, there it was a 1,300 pentamidine because that's when it was mixed, or we told them that's when it was due. So now we need to go into their MAR and just click and sign it off
Otherwise,
on the
it's
pentamidine,
free.
because we never did that before.
So can we go back? I
There's
just had
something
one
new
on
with
Monday.
going in 72 hours, but I don't think that's go live yet, was it?
Right now, it's only 24 hours, but within the next few days, it's going to be 72 hours, so it gives us some time to go back in and reconcile those.
I thought pharmacy did it, that's why.
I always thought so.
Why don't we just do it? You're not administering it now. Kicker.
This is a new process, and they're recognizing that it doesn't, but there's, the common canister is kind of one of those that is causing this new process some difficulties. Donna, can you speak to that?
The report that we can look at, just, now I have it on the Epic and I'm just clicking, there it is right there, but it doesn't include common canisters. That's, I think they're looking into seeing how they can get those on this report. So right now the common canisters don't show up. And then we did go over it this morning at the huddle. There was some question, if I scanned that little barcode on top twice, was that charging twice? You know, if 2 puffs are ordered, is that charging like 2 doses, 2 puffs? Jill's looking into that further, or if you just went into the MAR and clicked I gave it, as opposed to scanning it, even though we're supposed to scan it. Is there a difference in charges to the patient? So she's kind of looking into that. She didn't know offhand. But you can scan that little barcode on top 2 times, or go into that, when you get the red hand, go into say partial package and then add that you gave 2 puffs instead of 1.
Is there a way for them to put the dose that is ordered in, so that we don't have to, that's like a 5-step process
Mhm.
to scan in an inhaler.
But if you could
Not
go click,
even
click for 2 puffs,
I don't know that it necessarily lets us to do it
sometimes
twice.
it doesn't
Yes,
seem
it
like.
does.
You click
Yes,
once
it
and you
does.
have to like accept it or whatever, and then you click it again. and
It's
then
a
scan it
process.
again.
It's a process either way, so, I mean, I don't understand if they can put in a dose that is ordered.
I
on
think it
any
has to
other
do with
med.
the barcode, because the barcode's gonna say 1, no matter, the barcode is not gonna know if Symbicort's gonna be 1 or 2 puff, because it's common canister. So it could be for anybody, some have 1, some have 2. So I think that's the kicker, but she's looking into it. It is a process to get 2 things. That's why some people get frustrated, because they don't think they're doing it right, and then they just go in the MAR and sign it off.
So we have a couple different demonstrations today. Stephanie, well, actually it's not Stephanie, it is
Teresa.
Teresa is here. She's going to go over the MetaNet. I see, and then after that we have more presentations from the staff. So without further
Go
ado.
ahead.
So I didn't get a lot of information, but I'm kind of assuming that maybe Stephanie's done some servicing before, or at least they showed you guys the device.
They trialed it a while ago, but it didn't even look like this.
Okay, so you guys trialed the Medinib 3, so this is the Medinib 4. It looks a little better, which is a good thing. So my understanding is that this is just a quick interest on, showing you guys how to do it, and we're going to be starting a trial soon, again, on this one. So basically, what Medinib is, and I'm just going to kind of talk about it like you guys do not know anything about it. That way, if some of you guys, it's been a while, or you've never seen it, then you'll learn a little bit, hopefully. So what Medinib is it's kind of a combination device, and I'm a respiratory therapist also, so I should tell you guys that. That way, if you have any questions about using it with ventilators, although I've never used the Hamilton vent, but I hear it's a very nice vent.
Some days.
But if you have questions about, and just the usage of it, administering it, I have used it in the past. I've also used similar devices, IPV and IPVB. So what I like to consider it is a combination device. So it's kind of like an IPVB and like an IPV because it does secretion clearance and lung inflation. So Medinib, meaning that it does 3 different things. It does the aerosol at the same time. So hopefully, in the beginning when you learn new devices, it always takes a little bit of, there's a learning curve. This is a very simple device though, so I don't want anybody to be scared or nervous of it or anything like that. We say it's a 10-minute treatment, so you can do the lung inflation and then secretion clearance as well as deliver the aerosol at the same time in a 10-minute treatment. So hopefully it'll save you guys time in the long run, as opposed to doing multiple therapies concurrently. What do you guys use for secretion? I saw you guys had a vest, or several of them actually, at least 5 I saw downstairs. So I know you have that. Do you use acapella, easy pap, anything like that? Okay. So hopefully this will eventually take the place of that, or at least help eliminate some of those where you're doing multiple different things on the same patient. So it is a single patient disposable use circuit. We say it's good for 7 days or 30 treatments, kind of whichever one happens first. Some places honestly use it longer. That'd be a little bit different than just using it on a spontaneously breathing patient. So I'll talk about the spontaneously breathing patient first. So your mask, your mouthpiece, or a trach tube adapter to a trach. For the 10-minute treatment, you're going to usually start off in the lung inflation part. And it's called CPAP on this one, continuous positive expiratory pressure, so European for CPAP, whatever you want to call it. And it is controlled by this flow knob at the bottom. Sorry, kind of. And what you're going to do is you're just going to kind of start off and have the patient breathe nice and slow through it normally as possible, and slowly increase the flow till, and you're going to watch the pressure manometer. Now I know the pressure manometer goes up to 100, but the pressure does not go that high. You're going to watch it till it's about 6 to 8, and sometimes people say between like 4 and 8. It's going to just kind of depend on the patient. You obviously want to make sure that it's giving them a deeper breath, so if you've ever done an IPPB, you kind of know how that, when you increase the flow, how that felt as it just giving you a deeper breath. You're just going to kind of watch the patient. And again, you can do that by listening to them. And if they can tell you, yeah, this feels pretty good, it feels like I'm getting a deeper breath this way, you're going to just kind of watch them. And then the other thing with this handset, you can actually dial in your expiratory resistance. So there's 3 little dots here. The one dot being the easiest, so the largest expiratory hole against it. So this is like your PEP device. Okay, so there's 3 little dots, 3 being the smallest expiratory hole, so it's going to be quite a bit more resistance. And the handset itself works off the Venturi's principle, so it's a flow amplifier and which creates suction, which helps the device work. But it's also a safety mechanism. It doesn't allow the plateau pressure to go over 30. Okay, so a little bit safer for some patients as opposed to using like an IPV, if you guys have used that before, where you can really dial up the pressure. and you have to be pretty careful. But this again doesn't allow the plateau pressure to go over 30. So if you're watching it, your peak pressures may go a little bit higher than that, especially if the patient's coughing, something like that. But the plateau pressure will never go over 30. And again, being that it works on the Venturi principle, there is an air entrainment port at the back here. So you will feel air escaping out the back. Okay, so that is completely normal. As far as medications in the nebulizer, albuterol, Atrovent, Xopenex, whatever you guys use, Pulmicort's used in there quite often. You're not obviously going to use pentamidine, like I heard you guys say you do, an inhaled antibiotic. Pulmozyme I wouldn't do through here. A lot of places do use hypertonic saline. If you guys do that, they do use that through here. You just want to make sure that if you use something that's like Mucomist or something like that that's pretty thick and sticky, that you rinse it out in between each use and let it kind of dry good. So again, back to this, the nice slow deep breaths, continuous positive expiratory pressure, you're going to slowly increase the flow to get that nice deep breath. If it feels like the patient is taking a little bit, you know, they're like, hey, that's enough flow, but you feel like, you know, you want to give them a deeper breath still, that's when you can kind of adjust this PEP here. So that expiratory resistance. So with a 10-minute treatment, you're just going to do a few minutes of this. I mean, you don't have to look at your watch and say, okay, it's been 2.5 minutes, now we have to switch. You know, as long as you're close, just do a couple minutes of lung inflation to just really stretch out their lungs, do a little bit of chest physical therapy as far as making them take deeper breaths and stretching out the lungs. Do that for a couple minutes, and then you're going to switch it up to this CHFO mode, which is continuous high frequency oscillation. So that's like your internal vest, okay? And then that one is controlled by this top button here. So there's 2 breath rates. Who's used an IPV before? Okay, do you guys have those here? Yeah. Awesome. So you know how with IPV you can go from like 100 to 300, and Dr. Bird always said to, you know, vary your frequency throughout the treatment. Well, this one they did, they just kind of did a study, I guess, and did some determination on what was most effective as far as breath rate, and I guess that's how they came up with these 2 breath rates. So you have a high breath rate and a low breath rate. The high is 230 breaths per minute, the low is 170. Not really sure why they picked those, but I guess they thought that that's what was most therapeutic. So again, high breath rate is your 230, low is 170. So honestly, we say to start at the high breath rate, and what I tell people is, at least, you know, when your patient is doing the treatment, if they feel like, you know, that's just a little bit too much, if you start on the high breath rate, you can say, okay, let me turn it down, and then you have somewhere to go. When you start on the low one, and then you switch it back up to the high, sometimes it's, you know, it's louder, it's faster, so sometimes that frees patients out a little bit more. Does that make sense? Mm-hmm. So I always say start at the top, and then you have somewhere down to go, at least. The other button here is this middle one here, and it's purely just for the aerosol. So obviously you're never going to use this just for an aerosol treatment, way too expensive for that. But if you have a patient that's not tolerating it or just needs a break for a few minutes, but you want to continue to administer the medication, you can just turn it into that middle one, which is the aerosol mode. And that's about all there is to the device.
I have a question. You said it has an Venturi and you have it hooked up to an oxygen tank or a quick connect cut on the wall. What FiO2 are you delivering?
It's a great question. Anywhere between like 38 and 52%.
Okay.
So if you really have to know, you're going to have to put an analyzer in line. Because again, with the Venturi principle, you know, we could be pulling in 1 molecule of oxygen and 5 or 6 with one patient, and you know, maybe only 2 or 3 air molecules with another patient. So it really depends on the patient.
Mid-40s average.
Yes.
Okay.
So yeah, I would say probably approximately 40%.
Okay.
But again, it's going to vary. If you do have to know, just check with an analyzer.
But it's not 100%.
No. I mean, obviously there's 100% coming from the machine, but because of the Venturi, you're never going to
You
get
might
that.
make that assumption.
Yes.
Okay.
So do you encourage the patient to keep their mouth mask or mouthpiece tight?
Yes. So that's
Inhalation and
yes. And it will work on inhalation and exhalation. I'm going to use, I brought my circuit, my circuit so that I can use it. And I can kind of show you how it's done. This is an older one, that's why the filter's a little bit bigger. This is the newer, so that's why it's a little different. So, starting it off, just gonna turn the toggle switch on. And again, instruct the patient to take nice, slow, deep breaths. I usually start off with the PEP, you can start off at 2, and then you have somewhere to go up and down. Or if you have a patient that you're just kind of worried that they're not gonna tolerate it, you know, that's kind of up to your discretion. Like I said, I usually start at 2 on here, and then you have somewhere to go up and down. So, the toggle switch is on. There's about 5 to 7 liters coming through the nebulizer at all times just to run it. You always want to run something through there, so if the patient doesn't have a medication, I would just use like a little pinky of saline just to keep those secretions hydrated. So again, nice slow deep breaths, and you're going to just watch the manometer slowly increase the flow. Do that for a couple minutes, and again, you can change this throughout the treatment. And then you're going to flip it up to the top. I would always, you know, I'm sure you guys already do this, it's just sometimes I talk to places that don't explain everything to the patients. Explain to them what it's going to sound like when you flip it up, because it is kind of, it is loud, again, just like your IPVs, you know, I mean, it's kind of an obnoxious sound. So you want to let the patients know that that's what's going to happen so that they don't get scared. A lot of the times I'll just kind of turn it on and let them listen to it for a second so that they know what's going to happen after a couple minutes of that lung inflation. So then a couple minutes of that, switch to your lung inflation. You should be able to see the patient's chest moving. And you can, again, what I was getting at and going to show you, if you don't keep your cheeks tight, you will, it's obviously just going to go into your cheeks. So you want to keep them, encourage them to keep their cheeks tight as much as possible. If they can't, then that's probably going to be your good candidate for trying to mask treatment on them. Now you don't have to have like a super tight seal, you know, like a BiPAP. I mean, you don't have to worry about that. A little bit of a leak, it's going to kind of it's going to compensate for that. So it's going to be okay to have a little bit of a leak. Because we don't use nose clips or anything like that. You don't have to worry about that. But if they can't keep their cheeks tight somewhat, then yes, you want to probably move them to a mask. And again, you can just kind of hold it on their face. You don't have to swish it down or anything like that. But you want to be able to obviously make sure that, you know, it's comfortable for them. They're able to take their deep breaths on their own.
So they don't have a different mouthpiece?
There is a mouthpiece that comes with it. So with the, this little bag comes into it. And there are a couple things. So the mouthpiece, there's a 15 to 22 millimeter adapter and then a 22 millimeter adapter. And then the other thing is this black selector ring. So this black ring is for your, in line with the ventilator use. Because it works on the venturi and because you have this, this expiratory hole here with the ventilator, obviously they're exhaling through the ventilator, so you want to close that up. So you're going to use this little black ring to just plug up this hole here, which is your expiratory hole, okay? It's actually pretty simple. So what I tell people, always keep this back, don't throw it away. Just tape it to the machine, tape it to the side of the head of the bed, put it with your other nebulizer, all your other respiratory supplies that are in the patient's room, that type of thing, just so that it doesn't get lost. You can get them extra, but obviously it's not as convenient to run back to the department and grab this little black ring if you needed to do it. So in line with the ventilator, you're gonna put it in line on the inspiratory limb. And then do you guys
I have a circuit there, just so you could show where in the vent circuit it goes. Or I just put it.
and then do you guys do any so we would just do you do nebs or just inhalers on your ventilated patients?
Urgent.
Okay. So with that, do you have any spring T adapters?
Yes.
Okay, so I know that with the, so you're just gonna, yeah, with your circuit.
Never mind. Doesn't come apart.
So that's
Can you
good.
do it at the
Down by the
machine?
filter.
Can you
Typically,
do it
the
at the
circuit should be
machine by
at
the
huge
green
unified
phone?
circuits anyway, and those do come apart. So
This one's just a dry circuit.
Okay, so yes. So then, yeah, you would just pull it off on the inspiratory limb and stick that spring T adapter in line.
Okay.
Okay, then the spring T adapter, you're just gonna turn it to the side so that it's facing outward. And then you'll use this adapter here. And then just pop the end out of the spring T adapter and then stick it in line. The key to using it in line though is to turn this machine on first. Because you have that pressure built up in the vent circuit. Because of the venturi, if you stick it in there without turning the machine on first, all of the air is gonna escape through the back of the venturi. Does that make sense? So you'll know if it happens because your vent's gonna start alarming like crazy.
And don't leave it in line.
Yeah, don't leave it in line, right? Especially because then you're gonna turn the machine off. But obviously, the spring T, just close up that little, the little end, and then it'll be fine. But that's really the only key. The other thing with using it in line with the ventilator is you probably already have PEEP on the ventilator, so you don't need to do this lung inflation portion. You're just gonna do the high frequency oscillation part. So, and you could do that for 10 minutes. We don't recommend leaving the patient. I don't know what your guys' policies are, but if there is something in there, it's kind of like an IPV treatment. If there's something there, it's gonna move it up. So you're gonna need to be there to suction the patient.
Is that adding volume then? So you're just hooking up the oscillation. How much volume is that adding if you just keep the PEEP off? Are you adding anything to the
Well,
circuit?
there's still 5 to 7 liters pushing through the ventilator, or pushing through the nebulizer, yes. So there is gonna be a little bit, yes. So again, with your alarms, you're gonna have to check your alarms. You may have to change them a little bit or stand there and hit silence. Because depending on how tightly set your alarms are, it is, your minute ventilation is gonna change, your external tidal volume is gonna change a little bit.
Hamilton does have settings that they recommend you put the vent in when you're doing the meta-nav in line with the ventilator. So they actually have established some settings, say, hey, do this, this, and this if you're gonna do this in line, otherwise you'll have constant alarming. So they do have
Very nice.
that stuff written. We'll make sure we get that out on the devices too, so that you have that reference tool if you do it online, in line with the vent. All right.
Thank you.
She's gonna be here at 11. She's got a presentation that's worth 1 CEU. And then she'll also be at the evening department meeting to kind of go over it. And once we have everybody comfortable and signed off, then we will hopefully have some patients so we get the chance to try it out. So. I'm sorry? Mm-hmm. Yes. Megan, you're up.
All right, so I just wanted to give everybody an update on what I've been up to, what my day looks like typically. In the morning, I start out just printing a list out of Epic of primarily doing MAP, CTU, INC, and palliative. Then I'm getting a report every day on who the hospitalists are for that day. I also get a report from Kim, who is the manager of hospital clinical resources. She's working with the hospitalists. And then the house supervisor with a list of projected discharges for that day. And then I go through MediLinks and look what patients we are seeing, and that's how I didn't know who to focus on for the day. I'm going to rounds at 9 o'clock in medical. Starting in December, they're changing that to multidisciplinary rounds as a pilot for that unit. And then I also go to rounds at 2:30 with hospitalists, and that has been very helpful. Just getting feedback from them, projected discharges. I then follow up with the staff and let you guys know kind of updates on discharges or other things that are going on. Has it been helpful for you guys? Yes, no?
Yes.
Okay. I'm also working on a home care binder so that when I'm not here, home care setup for you guys will be as easy as possible. Updating all of the contacts for the home care companies, some of them on that green sheet don't even exist anymore. So everything you would need will be in that binder. Updating some of the qualification guidelines. Right now for the referral process, either a physician puts in an order for the home to eval, or you guys can if you think that is necessary. Staff on the floor is doing the walk test qualification, and then from there I contact the company and take care of all the paperwork and all of the follow-up afterwards. Any paperwork that's missing. I really did not realize how much running around and gathering of documentation and phone calls. So I can see how frustrating that it has been for you guys, having a full workload and having to deal with taking care of all of those things, especially with certain patients when their discharges are a long process. A couple of reminders for qualification. If they are needing more than 4 liters, the insurance requires documentation of what their SATs are on 4 liters, and then whatever their requirement is, whether it be 5 or 6. And they also cannot take qualifying SATs on a pendant. I know that we have done that in the past, but they really do need to be on a standard cannula first. And then if we want to send them home on a pendant, we can do that eval as well. Hypoxia is not accepted as a primary diagnosis. As far as home medical equipment is still occasionally accepting that, but no one else is. So I think it's best practice to just not use that at all for primary diagnosis. If they are hypoxic, there's got to be another reason for that. So just make sure that we're documenting the O2 checks on the flow sheet. The CNAs are not documenting liter flow, so when I'm going into the flow sheet and trying to see where they're at, that's been a little bit of a challenge. And there is also a new process for apria. Brad gave us this. Usually he's our primary contact person, even on the weekends. He has now a backup if he's not available that we can call, so I'll get that information posted. James and I are working on some charting changes. We're separating that right now. That home care documentation is the qualification piece, and choosing a home care company that's going to be separated out, so that whoever is doing the evaluation, it will be just that piece, and then I would document the equipment piece of it in the home care. For CPAP patients, if you want to just double check with them that they don't have any needs with their home care company or any questions. If they do, I can always follow up with them and help with that process. And then just a couple other things that I'm working on. There's a throughput committee, all the units and multiple disciplines working towards quicker and cleaner discharge process. And then the COPD committee working at ways that we can reduce those readmissions and coming up with some protocols for those patients. And I am going to be looking at the trach teaching booklet and that whole discharge process, getting some order sets built for that. We don't do a lot of trach discharges, but when we do, they tend to be a little messy. So we'll get that process cleaned up too. Any questions from you guys or feedback, what's working and what's not working?
Megan, do you think you could, or what diagnosis other than hypoxia just say like a post-op heart. Because we have a lot of heart patients that go post-op
Sure.
after that go home.
Yeah.
What kind of things are you looking for?
If they don't, the CHF is a qualifying diagnosis. So if they don't have a diagnosis of CHF, we can use hypoxia. I think what you put first is heart surgery, and that is acceptable. So,
Heart surgery?
well,
Is acceptable?
yeah. And you're just, you know, you have to work with the home care company on if they want something specific written, but usually if you can list a reason why they're hypoxic, if they, have this surgery.
For instance, we had that one patient that was hypoxic and that was it. No pulmonary history, no cardiac history.
Mhm.
However, did have a abdominal surgery
Right.
that was probably one of the culprits in causing this patient to be hypoxic. She had anemia and she had some other different things going on. So that had to be the primary, and then hypoxia had to be the secondary. So some surgical situations will qualify the
And the
patient.
physician's documentation is key, having that in the discharge summary. They're also looking for what the stats were in the discharge summary. So what I've been doing is just calling the physician and letting them know, your patient qualifies for oxygen, can you please just put that documentation in the discharge summary? And then I haven't had any issues with the home care companies calling back and saying that we're missing documentation.
And those qualifiers you'll have outlined in that book
Yes.
too, so.
We'll have a whole list of what the qualifying diagnoses are.
Okay. Thanks, Megan.
Yeah.
Oh, I totally forgot to bring this down. We're just gonna skip it for now. We've got a lot of other things to do. Julie?
Device integration is working.
Yeah.
A couple of little glitches. I'm not really sure why the iTime isn't pulling every time, but what's really weird is it's not pulling on our events that were running already, but the hearts that were being set up, it was consistently pulling, so I'm gonna have to look at that this weekend when I work, if we have some new event patients, like, is it just because they were there, but that doesn't make any sense because they weren't hooked up, so it's just one of those weird things. Auto peep actually, the total peep actually just pulls the auto peep instead of the total peep, so I can have Ruth change that to just say auto peep. So I'll send her an email for that. Don't erase or don't take out the ideal body weight and don't take out the cc's per kilogram for ideal body weight, because eventually we're gonna have a report for Dr. Laren for that. So just leave those in there. It's, you guys need to set that appropriately, the ideal body weight. I know some people are not going back in and changing that. So maybe even make it a habit to check on the shifts that you're, that's correctly put in there. Don't just leave it at 69 or 70, depending on whether it's a male or a female. Just try to go in and be cognizant of it. You're talking about an event? Yeah.
Well, when we had our in-service, the guy told me that we only had to set that if we were using the ASV mode or whatever.
I don't know,
It
that's not what
it calculates it no matter what you do.
Yeah.
It's on
But it doesn't change the settings.
No.
It doesn't.
No, it's just telling you what the ideal body weight for the patient is.
Oh.
And if you look over in that one far right left-hand corner, it tells you how many mils per kilogram you're delivering to your patient. So if you look at it, it'll say you're at a tidal volume of 8 liters, 8 mils per kilogram.
Like
If you have the wrong kilograms in there, if you have the wrong ideal body weight or the wrong height and wrong sex in there, that's gonna give you erroneous data. So if you say you've got a 7-foot man and you really have a 5-foot female, that is not going to be accurate. No, it doesn't, you control that, you change your settings and you can manipulate that. But really, it's there as a tool for the ventilator for you to be able to reference. It's gonna pull that data, so it should be set.
And if it's set appropriately, you don't even have to look at it again, it pulls it every time. So when you file, it's gonna be there. You can look at it, but unless it's changed, which it shouldn't be changed, it's always gonna be the same. So if you originally set it when you set the vent up, then you're done.
If you know it. Yeah.
And you may,
Pulling
and
them
you're
up.
right, you may not know it initially,
Right.
and you might be just doing the eye test going, 5'7", but when when the patient's there and you have time to take a look and find out what their actual height is, you need to adjust it then. I mean, that's just best practice. It's there, it's a tool, use it. Lung protective ventilation strategies, all the rage, we wanna make sure we're trying to keep our meals per kilo 6 to 8. So it's there.
And I have to kind of watch too, like, all the patients from yesterday that were live on this, were all on CMB. So, I mean, I have to kind of make sure things are still pulling in some of the other ones, but I'll kind of try to go around and look at that this weekend. But if anybody notices anything that's not kosher, please let me know, send me an email, and I'll get together with Ruth. She's gonna call me next week to see how things are going, so.
And is there a little bit of a delay or like pulling the information like after you have the event added?
It can take a minute or two to catch up.
Why they're just like
Yeah, it's
just like the
It's the
old.
same as always. It's, there's always gonna be a delay because it takes time for that data to start flowing in. Because it has to go from our system or from the capsule into the Epic and all of that stuff. So it takes time to flow like anything else.
Darn it. I suppose he wanted to see your
I told him
presentation.
when he
Thanks,
came in, I'm
Joy.
like, oh darn, I'm giving a talk on sepsis. I said, now I'm super nervous.
Oh,
Back on November 3rd and 4th, Michelle, B., Sarah, Kendall, and I went to Eau Claire to a critical care concept where it was a small class, 2-day class. We were with some nurses. Some were from even Kansas, over in Minnesota. So it was like a little diverse group, and we had topics like intracranial pressures, sepsis, respiratory failure. There were a lot of topics. Anyway, when we go to the conference, it was nice that Heidi let us go, and we want to come back with some information for staff. So I just put this little PowerPoint together of things that maybe I learned or just reinforced, and I found interesting. So I'm doing mine on sepsis, and I have what is sepsis? Sepsis is presence of pathological organisms. They're toxins in the blood and tissues. It's the body's response to an infection. It could be bacterial, viral, or fungal. Most likely causes pneumonia, abdominal or kidney infection, or septicemia, positive blood culture. There's 3 stages. It kind of goes back, there's like an actual sepsis committee, like an international, and they've had like 3 big meetings over since like the 80s, 90s, and so things change, but for right now, they're saying there's 3 stages of sepsis. The initial sepsis, then you go into severe, and then septic shock. And diagnosis includes probable or confirmed infection and at least 2 of these following: a fever over 101 or a low temp less than 36 Celsius, respiratory rate over 20, and then elevated heart rate over 90. And then you upgrade to severe sepsis, includes a sepsis, and then with at least one of these following: decreased urine output, difficulty breathing, abdominal pain, change in mental status or unconsciousness, and extreme weakness. And then septic shock, the most severe, is diagnosed if all the first things, at least one of the second things, and then if they're getting fluid replacement and their blood pressure, they're still hypotensive. Just some facts on sepsis: up to 1/2 of all hospital deaths are sepsis related. Septic patients are 8 times more likely to die during their hospitalization. And interesting, I didn't know this until I kind of looked into things. The CMS, that's the payers for Medicare, Medicaid, and we hear about the payers. They are collecting data to gauge if care of severe sepsis and septic shock patients are improving as they're here. Is the hospital doing the right things? So compliance will determine payments, forgot a T there, in the fiscal year 2017. So to me, that meant like July, I believe. And there are sepsis protocols that hospitals are using. It's as soon as they're diagnosed with sepsis, there's like a 6-hour protocol, and they're looking at, is the hospital doing and giving the right therapies? And then how does this pertain to RT? So assessment tools are available to help diagnose sepsis. There's this SOFA score, it's this sequential organ failure assessment score, and it really requires a lot of multiple tests, lab tests, that may not be timely when you're going into a room and looking at a patient. And what I found interesting was this Q-SOFA. It's a quick SOFA, or called a HAT acronym that can be used for a bedside assessment. So I thought this was interesting, and I thought we could use it during like a rapid response, or you get called to assess a patient, saying they just don't look good, and you're going down there, well, they don't need a neb. Like, that's not gonna help, but you're right, something's not right with them. And sometimes we just get called for that. So this quick SOFA points, if they get 2 points, presence of 2 or more of these, and we're saying put on your thinking hat, and it's HAT, hypotension, systolic blood pressure less than 100, altered mental status, and tachypnea, respiratory rate greater or equal to 22. 2 or more of these HAT points, it's a simple prompt identifications that could be outside the ICU, get called to assess a rapid response, who are likely to be septic. These patients are at greater risk for prolonged ICU stay or death. Early recognition is crucial. And then I also found interesting this lactic in sepsis. They did talk about that, and lactate levels increase with sepsis. And why is oxygen levels are low in the tissues. Carbohydrates break down energy and makes lactic acid. And lactate is a marker of cellular hypoxia. And we're looking at levels above 4. It's associated with 20% mortality rate compared with a 2.5 to 4 number. And also the half-life of lactate is around 20 minutes. Therefore, if it's consistently elevated, it's not that the body can't get rid of it, it's because the body's still producing and shifting into the anaerobic metabolism. Also, the arterial versus venous lactate levels do correlate, but trending should be generally applied instead of an absolute value. So we see somebody come in, there are things that can affect the lactate to be erroneous. Surgery or stress, like sometimes we'll always check lactate on the hearts when they come back, and sometimes that'll be, it seems like could be near 4, but there are things that can affect the lactate. But if you have somebody come in with a severe sepsis, you know, and all the signs, they can be up to highest 13 or 14, and then you're like, wow, that's high, and then we'll check it again, and if it's coming down, that means the therapies that we are instituting they're heading in the right direction. Treatment plan for sepsis, obtain blood cultures, start antibiotics ASAP, fluid administration for tissue perfusion. They may need inotropic therapy due to heart decreased contractility, blood products, and mechanical ventilation. And takeaway I got from it is use the quick SOFA or the HAT score during your assessment when called for assess patient or rapid response. Assist with septic diagnosis and early treatment, put your thinking hat on. Use of lactate is a helpful tool to assess severity and improve sepsis outcome. So I think maybe in the future we'll be hearing more about sepsis, or it's just some information that you could use. That's it. Was that all right?
It's really good. We're going to be doing the giving tree again this year. Hopefully, I think Deb said your goal is to get it up like Tuesday or something next week.
Yes.
So that we have a heads up before the shopping craze this coming week and weekend. And anything else to add? We cram a lot in to the department meeting. we're going to have the Hamilton ventilator educators are coming back. The end of this month, we'll have some sign-up sheets. I'll get them posted today. If you've been identified as a super user, you're going to get a super user class. And those super users are going to help educate the staff to help solidify some of these things, because if you learn it but then don't use it, it's really hard to retain it. So hopefully that'll help our super users feel more confident in helping folks out if they do have some issues. So the focal point is going to be other aspects that the ventilator can do. ASB is one of them, recruitment maneuvers and recruitability tools and waveform understanding, along with you guys generating some topics and questions that we want to have answered.
Could you include Heliox in that, with the new ventilator that we have?
Oh, sure,
Dedicated
sure,
thing that they're gonna teach?
yeah,
Okay,
for sure.
okay.
I'll add that to the list. And anything else, really, it's this go round, everybody has, if nothing else, at least a basic understanding of how the events work. So now is when you can kind of really get into it and say, okay, we'll go over the basics, but now what do you need more information on? Or what are you experiencing? What do you wish you could manipulate but not exactly sure how? Or those type of things. So that'll be coming, the sign-up sheet. He's going to be here for 3 days. There's like 90-some slots and opportunities for people to get in. The expectation is that everybody does it. Obviously, there might be some folks on vacation that can't. But having this super user group, having this intensive hands-on training, and then them also assisting and training others will hopefully help those folks feel more confident in providing information for staff. So, yes.
When is that? When is he coming?
November
29th. Oh, which is a Tuesday, starts in the afternoon.
Tuesday, Wednesday, Thursday.
How long are these slots? Is it like an
Hour.
1 hour.
They are an hour. There is going to be some online education. You'll be getting your link so that everybody can go in and do it. It's really the same process. You do your education, you bring your certificate saying, hey, I did it. Here's my ticket in to this wonderful class. So, all right? Thanks, everybody. Happy Thanksgiving. Have a good week. And if you don't want to take these with you, I'll keep them and we can